Welcome to our new CentoTalk. Today's webinar is about reproductive health and prenatal genetic testing. Today's webinar is led by Clarice Lowe, a clinical genetic liaison for CentoGene. Clarice serves the APAC region with best-in-class advice and genetic testing support to healthcare professionals. Today's key topics that she will speak about are clinical indication and genetic testing in prenatal cases, CentoScreen, CentoNIPT, microarray testing, CentoXome, and CentoGenome, as well as repeat expansion diseases. If you have any questions, please enter them into the Q&A chat and we will refer back to them at the end of the CentoTalk. I will now hand it over to Clarice.
Thank you, Francisca, and thank you everyone for joining today's webinar. Today, we'll be discussing on the role of genetic tests in reproductive health and what are the various genetic testing options available for the couples and parents before and during pregnancy. Let's start. So I have divided them into 3 sections according to the test methods available. They are first CentoScreen. CentoScreen is carrier screening. It's a genetic test that can be done before pregnancy. It allows individuals and couples to find out their chances of having a child with genetic disorder. So whether their child is at risk of inheriting genetic disorder, in particularly recessive disorder. I will then move on to talk about non-invasive prenatal testing, CentoNIPT. This test is widely used to detect common fetal chromosome trisomy and sex chromosome aneuploidies. Next, after NIPT, on the third part, I'll be focusing on the prenatal genetic diagnostic testing. I'll share mainly on the workflow when a prenatal testing is required, what are the sample requirements, and how is our medical reporting for the prenatal cases. So for all 3 parts, I will also be sharing test-specific case studies and case report after discussing each test features. First, let us talk about carrier screening. So what is carrier screening? Carrier screening is a type of genetic testing that is used to determine if a person is a carrier for specific autosomal recessive diseases. The goal of carrier screening is to help individuals understand their risk of having a child with genetic disorder and review the range of options available to guide pregnancy and family planning. Carrier screening and counseling ideally should be performed before pregnancy. Why does it important to be performed before pregnancy? So previous studies have demonstrated that on average, an individual is a carrier of around 2.8 pathogenic variants. Another study which sampled a large population, around 24,000 of individuals screened for 108 recessive disorder. The study presented that approximately 1 in 4 individuals were carriers for at least 1 disorder and 1 in 20 were carriers for multiple disorders. On another carrier screening study focusing on only 3 disorders, which are cystic fibrosis, Fragile X syndrome, and SMA, spinal muscular atrophy. Out of these 12,000 individuals screened, the study also reported that around 1 in 20 screened individuals were carriers of at least one of the 3 conditions. And of all these carriers, as high as 88% of them had no family history. Besides, 1 in 240 couples, they were carriers of a same condition, consequently resulted to an increased risk of giving birth to an affected child. So all in all, this shows that the importance and benefit of offering an expanded carrier screening to all pregnant women or couples considering pregnancy. Most people can be carriers without knowing it, and if both partners are carriers, they have a 25% risk of having an affected child with a recessive genetic diseases. So in CentoGene, we offer CentoScreen as the carrier screening panel. It's a very complete carrier screening test. As you can see, we include a total of 330 genes, which translated to 330 recessive disorders. So these genes, they were selected by our experts based on a few criteria, including the gene encodes for early onset diseases. The disorder are associated with highly severe phenotype, or the disorder has a high carrier frequency among the population, or if there is the availability of medical intervention for that specific disorder. Showing you here now in the darker color are some of the genes associated with disorder that characterized with a high carrier frequency, especially in the Asian population. So for example, pathogenic mutation in GJB2 is associated with hearing loss, and the carrier rates of various GJB2 mutation taken together is one of the highest in Asian population. The same goes with HbA1, HbA2, and HbB. They are associated with thalassemia. Others like ATP7B encodes for Wilson disease, CYP21A2 encodes for congenital adrenal hyperplasia, FMR1 for Fragile X syndrome, GALD for galactosemia, GBA Gaucher disease, PKHD1 for polycystic kidney disease, SMN1 for spinal muscular atrophy. So all these disorders are in relative rather common recessive disorder gene you might have heard before. So we have it included in this carrier screening panel. And the disease categories covered in this CentoScreen is a very comprehensive one, inclusive of basically from head to toes organ and system. So over here, like I mentioned, these are some of the more common recessive genetic diseases in Asian population, and we have all of this included in CentoScreen panel. So what are the test features for CentoScreen? The table chart showing here with all the details. You can also find the information on CentoScreen website. The panel is with next generation sequencing panel as backbone. The analysis will be inclusive of 330 genes by next generation sequencing. The coverage is at average of 99% at more than 20x. We include all relevant mutation from the mutation database, HGMD, and also published literature. Copy number variation detection is included for 34 selected genes using next generation sequencing data. All single nucleotide variants described in our in-house database, CentoNIPT, will also be covered, including those relevant deep intronic and regulatory variants. In addition, we have the auxiliary assay for the 3 technically challenging genes, which are FMR1 for Fragile X syndrome, SMN1 for spinal muscular atrophy, and CYP21A2 for the congenital adrenal hyperplasia. We, of course, also do confirmation of low-quality single nucleotide variants and all insertion deletion by single sequencing and all relevant deletion insertion variant by MLPA or qPCR prior to reporting. For CentoScreen report, due to its carrier screening test, we will only report curated pathogenic and likely pathogenic variant. And the turnaround time is 15 business days upon sample arrival in CentoScreen. Moving forward, who can benefit from CentoScreen? So CentoScreen can be offered to individuals considering pregnancy or during early pregnancy. It's appropriate for, first, couples without any family history of genetic disease to understand their genetic risk. Next is also appropriate for couples with a family history of genetic disease or such that their previous affected child is with genetic disease. It's also appropriate for couples from region with high consanguinity, and last, couples from any city with high incidence of certain genetic diseases. So one example of genetic condition that is more common in particular ethnic groups is sickle cell disease, which is more common in people of African American, or Mediterranean heritage. However, also it's important to note that this disorder can occur in any ethnic group. So do you know all people are likely to be carriers of several recessive genetic conditions? And carrier for this condition, they are healthy people. If the couples are carriers for the same gene, they are at 25% risk of passing of a given genetic disease onto their offspring with each pregnancy. A simple blood test is all that it takes to find out if the couples are carriers prior to pregnancy. This allows for reproductive planning, and carrier screening performed before pregnancy will allow physicians to provide your patient with a broader range of options and offer the family more time to make an informed decision. Let's now look at case study. So this couple, they are both healthy and without any family history of genetic disease. The mother is already pregnant with a baby at the time of testing using CentoScreen. We identify a pathogenic variant in HBB gene encodes for beta thalassemia. The inheritance mode for beta thalassemia is autosomal recessive. The mother is therefore a carrier of beta thalassemia. So with such result, the father has decided to also have the CentoScreen test. And the result of the father shows that he's also a carrier for a likely pathogenic variant in the HBB gene. Therefore, there is a 25% risk of passing beta thalassemia to their unborn child. In CentoGene, we have prenatal testing available for such case where both the parents are identified to be carriers of a same gene. I will talk about prenatal testing in the later part of this presentation. The conclusion for this case, as mentioned, both parents are carriers for beta thalassemia. Carriers do not show symptoms of the disease. However, carriers are able to pass the pathogenic or likely pathogenic variant onto their offspring. For CentoScreen, we do have different testing options available depending on the couples and the patient needs. Please contact our sales representative or visit to our website. For second case, this couple, they are healthy couple, but with family history. They had a deceased child. The child did not have the genetic testing done and no sample was taken and kept at that time. So the child was suspected with congenital disorder of glycosylation, and the couple was planning for another baby and worried about the recurrent risk. So after genetic counseling session for the parents, they then requested for a CentoScreen duo, which both will get their complete carrier testing evaluation. Let us now look at what are the results for this couple. So we identified that both are carriers for pathogenic and likely pathogenic variants in PMM2 gene. And the mutation in PMM2 gene is indeed encoded for congenital disorder of glycosylation. It's also important to note that this CentoScreen panel, although it's comprehensive, however, is still limited to a certain number of genes, which in this case is 330 genes. There is a possibility in another scenario or case that it might not identify the cause of previous child's death. And in some cases, if index patient sample is available, it's still best to do genetic testing using the index patient sample. So for this case number 2, after the couple knowing their reproductive risk, they can then consider the option that they have, depending also on countries and legal requirement for abortion. The family can consider to get pregnant and then do routine prenatal checkup and then prenatal diagnosis using chorionic villi sample or amniotic fluid sample. Another 2 options to consider, depending also on the ability and individual choice, are to do pre-implantation genetic diagnosis or to consider to use a sperm or egg donor. So carrier testing for other family member at risk, we highly recommend carrier testing for other families, especially those planning to have a child or are already pregnant. So in this pedigree, we can see that for partner 1, he's a carrier and he has 2 other siblings not knowing their own carrier status. Carrier testing for the identified variants, in this case, a likely pathogenic variant, can then be offered to both sisters of individual 1. A slight note to take as well, if one parent is a carrier, then it's recommended that the partner of the carrier to take a comprehensive carrier screening panel test that includes the gene of interest. Conclusion for case number 2, this is a couple with a family history such that their previous affected child was undiagnosed, and through CentoScreen dual, both parents are identified to be carriers for congenital disorder of glycosylation type 1A. Okay, moving forward, let us talk about non-invasive prenatal testing. Non-invasive prenatal testing is a method of finding out the risk that the fetus will be born with certain genetic abnormalities. This testing analyzes small fragments of DNA that are circulating in a pregnant woman's blood. We call this small fragment of circulating DNA as cell-free DNA. So during pregnancy, the mother bloodstream contains a mix of cell-free DNA that comes from her own cell and also cells from the placenta. The DNA in placenta cell is usually identical to the DNA of the fetus. Analyzing cell-free DNA from the placenta using maternal blood provides an opportunity for early detection of certain genetic abnormalities without harming the fetus. So NIPT is a screening test, which means that it will not give a definite answer about whether or not a fetus has a genetic condition. The test can estimate whether the risk of having certain condition is increased or decreased. In case of a positive screening result, further testing using prenatal diagnostic testing should be performed to confirm the result. So in CentoScreen, we have CentoNIPT as the solution for non-invasive prenatal testing. CentoNIPT screen for chromosome aneuploidies, including trisomy 21, 18, and 13, and also sex chromosome aneuploidies. So fetal gender can be determined by the test for singleton pregnancy over 12 weeks. For twin gestation, only the presence of Y chromosome can be determined. The sample needed for this test is 9 mL of maternal peripheral blood. Our optimized workflow with CAP and CLEAR accreditation will provide the ordering physician with a full medical report within 5 business days upon sample arrival in CentoScreen. Okay. So NIPT is not a diagnostic test, and positive results should be followed by a diagnostic test with amniocentesis or chronic villus sampling. While NIPT is often described as highly accurate, false positive and false negative results still exist. So follow-up of the fetal growth using ultrasound is mandatory even for negative result. In case of abnormalities observed on the ultrasound examination, or if there is positive family history, we recommend to follow up with prenatal diagnostic testing to confirm the result and check for other problems NIPT cannot detect. I'd like to share with you as well the look of our comprehensive clinical reports for CentoNIPT testing. So this is a sample report for positive finding. On first page of the report, it's important to have all the key features loud and clear. So as you can see, there's a pictogram of clear diagnosis and the summary of the interpretation of this result. Following directly is the specific recommendation for individual cases. On second page, you can find further details for the methods and limitation for this test. And also result summary is presented in a clear table form with information including fetal gender and also fetal fraction. And further off, you can also find the breakdown of sensitivity and specificity for trisomy 21, 18, and 13. The numbers will be specific for each individual cases. Going forward to the next topic, we will now look into the prenatal diagnostic testing portfolio. A bit of introduction. So approximately 2 to 4% of pregnancy are complicated by birth defects or genetic disorder. So we talk about non-invasive prenatal testing and NIPT testing. We now look at prenatal diagnostic genetic testing. So it focuses on pursuing additional details information and allows the pregnant woman to know with as much certainty as possible whether her pregnancy may be affected by genetic condition. And for this prenatal diagnostic testing, in order to obtain fetal sample, the operating procedure is through amniocentesis or chronic villus sampling. So this procedure, they are deemed to be invasive. They carry a small but potential risk of pregnancy loss. Therefore, it's advisable that pregnant women and family receive a thorough pre-test counseling regarding the risk and benefit of available option. The prenatal testing strategy and test selection should always be guided by prenatal imaging and family history, such that if result of the test from routine prenatal care, including ultrasonography and blood tests, suggest an increased risk of having a baby with genetic or chromosomal abnormalities, a prenatal diagnostic testing should be considered. Here is a look of our workflow for the prenatal test approval process and test ordering process. The reason for prenatal approval is required again is because to obtain fetal sample, the only methodology available presently is through amniocentesis or chronic villus sampling, which they are invasive procedure and carry some risk of miscarriage. So according to German's law and regulation, if there is no substantial evidence of possible fetal abnormality, the risk of screening do not outbalance the risk of possible miscarriage after the invasive procedure. Therefore, prenatal case review and approval is needed before sampling for prenatal genetic diagnosis. Please kindly obtain the approval by contacting your sales representative or CentoScreen customer support prior to sending the sample. The information that we need you to provide for our medical team and expert to review the case, including but not limited to ultrasound finding, clinical suspicious or available family history. After medical expert review the case, ordering physician will then be informed about case approval or non-approval. Usually the approval process will take less than a day as we prioritize highly on prenatal cases due to we understand the time constraint nature for prenatal cases. So wherever the approval is granted, operation to perform amniocentesis or chronic villus sampling can then be arranged. And next, the sample can send to CentoScreen using a reliable worldwide courier. Upon sample arrival in CentoScreen, the sample will then be processed and the data be evaluated. Medical reports will be ready within 7 to 15 business days, depends on the type of the test requested and also on the condition if the sample without needing the cell culturing procedure. Ordering physician can then download the patient report through our online ordering portal called CentoPortal. Next, let us now look into details on what are the required information for approval process and test ordering. First of all, if there is a known familial variant which previously identified in another affected family members, in such scenario, prenatal carrier testing can be considered. So for carrier testing of single nucleotide variants or small insertion deletion variant, please provide us the gene information, including the transcript number, the coding position, and protein position if available. For copy number variation, deletion or duplication, we will need the transcript and reference genome information. In addition, we also need genomics coordinates of the deletion duplication variant. In the case when there is no family history or familial variants, the clinical information from routine prenatal examination will then be mandatory. For such cases, when there is abnormalities observed during the routine, say ultrasound screening, or if there is the presence of abnormal result in the maternal blood and serum testing, the prenatal test that can be considered includes centroexome, centrogenome, which is whole exome and whole genome sequencing, microarray testing, and repeat expansion analysis. Repeat expansion analysis can also be offered to family with positive family history of trinucleotide repeat expansion diseases. Elaborating further on the mandatory information for prenatal analysis, please provide us this listed information wherever present. So this information including maternal age, gestational age, ultrasound abnormalities findings, including fetal symptoms and fetal MRI report. Previous tests and results such as NIPT analysis, karyotyping analysis, other clinical information which can be result from maternal blood and serum tests as an indication that the pregnant woman is at increased risk for having a baby with certain birth defects, for example, neural tube defects or chromosomal disorder. If there is presence of positive family history, please indicate the relationship of the affected individuals with the prenatal index. The information can be in written or in pedigree form. And all these information are important details to our prenatal and medical team, such that through this way, they are able to then get a full clinical pictures of your patient, the pregnant lady, and the fetal development. Okay. So on this slide, I would like to share with you on what are the prenatal testing options available at CentoScreen. On the left-hand side, these are genetic test options accepted for prenatal testing. First, we do offer carrier testing for known familial pathogenic or likely pathogenic variant. Next, if there is a positive family history of a specific known disorder that is associated with only one gene, in such cases, we could offer single gene analysis using Sanger and qPCR or MLPA testing. When there are one or more findings from the ultrasound examination, which can be difficult to pinpoint to a specific disorder, whole exome and whole genome sequencing can be considered. Please note that CentoGene, whole exome and whole genome sequences, CentoExome and CentoGenome. In prenatal analysis, we do not include the next generation sequencing NGS-based copy number version analysis. If detection of copy number version is required, especially when there is a suspicious of chromosomal abnormalities, central array cyto, which is the microarray testing, should then be considered. And as mentioned, we also do offer repeat expansion analysis on specific diseases. Moving to the right-hand side, these are the test options that are not available for prenatal testing. You can find these test options in the postnatal testing portfolio, but not in the prenatal testing portfolio. So we do not offer NGS panel, NGS-based copy number version analysis, Central LCV, which is the copy number version analysis using the shallow whole genome sequencing technology. We also do not offer mitochondrial genome testing and biomarkers, biochemical tests for the prenatal cases. Moving forward, which are the sample requirements that can be accepted for prenatal testing? So in CentoGene, we accept prenatal sample from any of these 5 materials: chronic villi, amniotic fluid, fetal purified DNA, culture cells, and cord blood. You can find the sample requirement details for each of these 5 materials on our website. So far, chronic villi sample and amniotic fluid sample are the most frequently received prenatal sample in our lab. For chronic villi sample, a minimum of 10 clean villi is required. The chronic villi sample should be transported in a minimum of 35 ml of RPMI medium with fetal cow serum. The sample must be clean and white with no cloudy medium. Cloudy medium hints at bacterial or fungal contamination, and contamination can reduce sample integrity and leads to analytical problems. For amniotic fluid sample, a minimum of 10 ml is required. The sample must be clear and without visible blood contamination. So apart from fetal sample, we highly recommend to also send along maternal sample. The use of maternal sample is for the maternal cell contamination marker test, is to determine the level of maternal contamination in fetal sample and to ensure that the sample is not compromised by maternal cell. Both fetal and maternal sample should be sent together in a single package. Please also do take note that to never allow sample to freeze or be exposed to temperature below 4 Celsius, such that cooling can cause cell damage and hinder culturing. The shipping of the sample should be at room temperature. So for details of each sample requirement, please visit to our website, www.centogene.com. On our web homepage, on the top of the panel, you can find the diagnostic tab. Click on the diagnostic tab. A drop-down menu will then appear. Then please go to the left-hand side of the menu and click on how to order. You then land onto the sample requirement page. And in this page, you can find the details for each sample requirement. In addition, you can also find prenatal sampling and shipping information in this prenatal sample instruction documents. Continue from previous slides. Here are some notes to be taken for sample sampling and delivery. So as I mentioned earlier, samples should be kept at room temperature at all times. Sample must be delivered in a safe seal Falcon tube with paraffin to minimize the risk of bacterial or fungi contamination. Please also ship the sample on the same day of sampling or as soon after collection. A reliable worldwide courier should be considered, and please do provide us the logistic tracking number to ensure easy tracking and safe delivery of the prenatal sample. In the case that the prenatal sample is with insufficient amount or the sample is with poor quality, our lab will proceed to do cell culturing in order to obtain sufficient amount of DNA. Please note that if the cell culture step is needed, then an average of 10 to 15 days should be added on top of the TAT of the analysis. Lastly, for packaging of the fetus sample, you can refer to the image here to pack it accordance with IATA regulation. All this information are also available on our website. You can find them in the prenatal samples instruction document. Okay, as I pointed out in the last slide, the chronic villi sample must be clean and white, and amniotic fluid samples must be clear and without visible blood contamination. So the left-hand side image here is showing you the ideal, appropriate look of the ideal amniotic fluid sample. In contrast, on the right-hand side, these are some of the examples where the amniotic fluid sample are in bad condition with risk of contamination. Moving on, let's now talk about how is our medical reporting for the prenatal cases, in particularly cases that requested for whole exome and whole genome sequencing, centroexome, centrogenome. So centroexome and centrogenome, they are phenotype-driven analysis. With that, all relevant variants in the prenatal list related to the phenotype of the fetus will be evaluated. But of course, in the first hand, the phenotypes have to be provided to us. It's highly recommended that ordering clinician to provide comprehensive clinical information, including relevant family history. So for prenatal analysis, essentially we report clinically relevant gene variants in known disease gene consistent with the reported fetal phenotype. And for this clinically relevant gene variant, we only report pathogenic and likely pathogenic variant that was classified using our stringent in-house SOP and also ACMG variant interpretation guideline. In very rare cases, variants of uncertain significance is reported due to that the variants satisfy a few conditions. As such, the variance is associated highly with the fetal phenotype, and there was no detectable pathogenic or likely pathogenic variant to explain the fetal phenotype. Possibility also when the VUS variants not only fits highly with the fetal phenotype, but is associated with a recessive condition, and that the VUS variant is found to be entranced with a pathogenic or likely pathogenic variants. Please note that we do not report variants associated with late onset diseases such as Alzheimer's disease, and we also do not report on cancer genes in particularly that cause late onset diseases. Let's go back to what we were discussing earlier when I talked about centroexome and centrogenome. They are phenotype-driven analysis. We will, of course, report the clinically relevant gene variants that is consistent with the fetal phenotype. In addition, data from prenatal centroexome or centrogenome may provide new information unrelated to the fetal phenotype, but known to cause early onset severe disorder. And many of these early onset severe disorder like neurodevelopmental disorder, metabolic disorder, non-syndromic intellectual disability, they are without known prenatal characteristic and not detectable with fetal imaging. As such, our expert geneticists and medical doctors, they put together a prenatal gene list that includes a selection of highly penetrant genes and are known to be associated with early onset severe diseases. The list of genes covered currently includes more than 2,000 genes, which are also frequently reviewed and updated. You might ask now, what is the medical reporting rules for variants coming from this prenatal gene list? So we only report the pathogenic or likely pathogenic variants from the prenatal gene list, and with also one precondition that it is not on a carrier status. If the variant is on a carrier status, the variant possesses no increased risk of developing disease, and therefore we will not report the variants. As for ACMG incidental finding and research finding, they are not available for prenatal testing. Okay, moving forward, after medical report is released onto the ordering clinician, what would be the next step? So we recommend to have post-test counseling regardless of the test result for the pregnant lady and her family. It should be provided by individuals with relevant expertise, preferably a genetics professional. So for negative diagnosis, it should be noted that the negative prenatal exome or genome's result does not exclude a genetic diagnosis, and prenatal care should be still based on available information from routine prenatal examination and ultrasound screening. If a positive diagnosis is made, the pregnant woman should be referred immediately to discuss the implication of the findings. The prospective parents both should attend the genetic counseling visit when possible. The genetic counselor or medical geneticist may provide the patient or couples with available information about implication of the findings for the baby's health and development, and also discuss the uncertainty if indicated, and review available options, including parental testing, additional fetal testing, testing of family members, and the availability of pregnancy termination. Okay, let us now look at some case studies. Case number 1. Mother of this fetus for this case at the time of test request, she was 31 years old. This is her second pregnancy. She has one child who is healthy and there was no family history. However, during her routine prenatal screening, the ultrasound testing reveals there is a fetal nuclear translucency with increase in thickness. And increased thickness of the nuclear translucency might indicate increased probability that the fetus will be affected by a chromosomal abnormality or congenital cardiac defects or even intrauterine fetal death. So typically, nuclear translucency alone is not sufficient to reach a diagnosis. When screening is positive, prenatal testing is then required to confirm the presence of genetic abnormality. So back to this case, with the positive ultrasound finding, ordering physician then asked for the approval for prenatal chromosomal microarray testing. Approval was granted by our prenatal team after reviewing the clinical information. The mother then decided to request for microarray testing using high-density central array cyto. Operation was arranged through sampling for amniotic fluid sample. The amniotic fluid sample then and also maternal sample were then sent to CentoScreen for the prenatal diagnostic analysis. The result was released about 2 weeks after the sample arrived in CentoScreen with positive findings of 2 pathogenic copy number variants. The finding of the 2 copy number version, one with chromosome 2 deletion and one with chromosome 9 duplication. These are suggestive of a possible translocation between chromosome 2 and chromosome 9. With such retrospective clinical correlation is recommended. And in addition, fluorescent in-situ hybridization evaluation is recommended to confirm a possible translocation between chromosome 2 and 9. Going to our case number 2, the mother was with advanced maternal age at the time of pregnancy and also test requests. This is her 4th pregnancy. She has had 3 unaffected children. During her routine prenatal screening with the ultrasound test, clinical finding of cystic hygroma, pericardial infusion, and pleural infusion was identified. With the positive ultrasound finding, ordering physician then suspect of chromosomal related disorder and asked for approval for the prenatal chromosomal microarray testing. Approval was granted by our prenatal team after reviewing the clinical information. The family then decided to request for microarray testing using high-density central array cyto. Operation was performed to sampling for the fetal sample via amniotic fluid sample. The sample and the fetal sample and maternal sample were then sent to CentoScreen for the prenatal diagnostic analysis. The result was released 2 to 3 weeks after the samples arrived in CentoScreen with a positive finding of a chromosome 18 duplication. The result was compatible with the genetic diagnosis of Edwards syndromes. Along with prenatal microarray testing, maternal contamination marker test was also performed. So it was reported that significant maternal cell contamination was not detected and is therefore unlikely to have interfered with the reported fetal result. Going forward to case number 3, the mother of the fetus has had 1 child who is healthy and there was no family history. This is her 2nd pregnancy. So during her routine prenatal screening, ultrasound tests revealed several clinical findings, including inlets, ventricular septal defects, fullness of paranasal tissue, edemas of the dorsum of feet, increased nuchal translucency, and abnormality of the forehead. So karyotyping was performed previously in an external lab, and the result was with normal finding. In view of the negative karyotyping and also significant fetal anomalies revealed by the ultrasound scan, the ordering physician then requested for the approval of prenatal central exome, which is the whole exome sequencing. The case was approved and operation was arranged to sampling for fetal sample. Both fetal and maternal sample were then sent to CentoScreen for the prenatal diagnostic analysis. The result was released with a positive finding of a heterozygous pathogenic variant in the KIF11 gene. The variant is a splice site variant. With such detection and interpretation of this pathogenic variant, the genetic diagnosis of autosomal dominant disorder is then confirmed. Parental carrier testing is recommended to establish whether the detected variant is inherited or de novo. Next case, case number 4. The mother of the fetus previously had 2 pregnancies and gave birth to 2 children, but sadly both the children passed away shortly after birth due to possibly propionic acidemia. And from the pedigree, as you can see, she and her husband are closely related. It's known that children born to consanguineous parents are at increased risk to genetic disorder, in particularly recessive disorder. So concerned about the recurrent risk, the ordering physician requested for approval of prenatal central exome trio. The case was reviewed and approved by our prenatal team. Subsequently, operation was arranged to sampling for fetal sample. Chronic villi sample was taken and maternal and paternal blood were collected using CentoCards. All the sample were then sent to CentoScreen. The result was released with a negative finding for the fetal sample. No clinically relevant variants related to the suspected familial phenotypes was identified in this fetus. Further evaluation for the parental samples reveals that both the parents are carriers for 2 heterozygous likely pathogenic and pathogenic variant. So the likely pathogenic variants was identified in the PCCB gene and codes for propionic acidemia, and the other identified pathogenic variants was in HBB gene, which encodes for the sickle cell anemia or beta thalassemia. The result of the parents indicates an increased risk for their offspring in every pregnancy to be possibly affected with autosomal recessive propionic acidemia and HBB gene-related disorder. On to our final case study in this presentation. Mother of the fetus has an affected son with Fragile X syndrome. This is her second pregnancy. She previously had the repeat expansion testing done and herself is a heterozygous carrier of an expansion in the FMR1 gene in the pre-mutation range. So in view that women with the pre-mutation have an increased risk of having a child with Fragile X syndrome in every pregnancy, the ordering physician hence requests for the prenatal FMR1 repeat expansion analysis. I'd like to point out again that clinical information and family history are important for prenatal cases. And the case was reviewed and approved by our prenatal team based on the provided family history. And subsequently, operation was arranged to sampling for fetal sample. So both samples, both fetal and maternal sample were then sent to CentoScreen at week 14. The result was released 2 weeks later with a positive finding of a hemizygous expansion in the full penetrance range in the FMR1 gene. The CGG segment was repeated more than 200 times, around 259 to 268 repeats. The result confirmed the diagnosis of Fragile X syndrome in this case number 5. Okay, I'm now approaching the end of my presentation. Let me just run through the key topics again. So in CentoScreen, we have a complete pre and post test, pre and postnatal portfolio. Before pregnancy, we have carrier screening test called CentoScreen to allow prospective parents to find out if they are carriers for a genetic disorder. During pregnancy, we offer a comprehensive package starting with NIPT for most common chromosome aneuploidies to prenatal carrier testing, microarrays, whole exome, whole genome sequencing for the invasive prenatal testing. After birth, we offer biochemical testing, enzymatic activity testing, biomarker testing, and our whole genetic test portfolio, including comprehensive NGS panel, whole exome, whole genome sequencing, centroexome, centrogenome, and specialized genetic analysis for critically ill newborns in ICU, Cento ICU. In conclusion, as mentioned, at CentoScreen, we have a broad portfolio to guide genetic tests for different moments and medical requirements through every stage of life. Choosing the right genetic test is critical. Your sales representative and our customer service are gladly to provide the support. Talking about products, CentoNIPT is a non-invasive test. It's ideal to screen for the most common chromosomal aneuploidies. Gender information will only be provided after 12 weeks of gestation. Approval is not needed for non-invasive analysis, CentoNIPT also not needed for carrier screening test, CentoScreen. However, approval is necessary for prenatal analysis, including single gene testing, carrier testing for specific genetic variants, microarray, CentoArray cyto, whole exome and whole genome sequencing, centroexome and centrogenome, prior to the operation procedure sampling for prenatal sample. And finally, I cannot emphasize enough, clinical information is essential for the evaluation of prenatal inquiry, including known familial variants with reports, family history, and clinical information for the index. Thank you for listening. I hope you will have gained an insight into the various genetic testing options available for the couples and parents before and during pregnancy. And now I'll be happy to answer any question you may have.
Thank you, Clarice. That was a very interesting and such a detailed overview. Like Clarice said, we will now move on to our Q&A session, and I can see that we already received a few. Let's start with the first question. The first question I have here is, should I choose between CVS and amniocentesis?
Okay, so at CentoScreen, we accept both chronic venous sample or amniotic fluid sample. So there's no differences in success between these two as long as sample requirements are fulfilled. And consideration between the CVS or amniocentesis should lie in the availability of the expertise of surgeon in performing chronic venous sampling or amniocentesis at the hospital. And another consideration will be the gestational periods of the pregnancy woman. So in general, CVS is done at 10 to 13 weeks of gestation, and amniocentesis is done between 15 to 20 weeks of gestation.
Thank you, Clarice, and thank you for the question. The second question that we have is there a reason to consider microarray in addition to WES and WGS for prenatal test?
Thank you for the question. So because centroexome and centrogenome-based copy number version analysis and also CentoLCV, which is the shallow whole genome sequencing, using the shallow whole genome sequencing technology, they are not available for prenatal or ongoing pregnancy cases. So unlike the postnatal portfolio, for prenatal cases, an addition of microarrays for centroexome or centrogenome should be considered, especially there is a suspect for chromosome-related disorder. And microarray not only can detect copy number variation, but also are able to detect region exhibiting loss of heterozygosity, UPD, the uniparental disomy, and also mosaicism. And for many years, microarrays has already been validated for copy number variance analysis for prenatal sample.
Okay, thank you. We do have further questions. Clarice, I think it would be great if you would take over. There are so many questions.
Okay, I can see there's a question. The person asked why we can't do prenatal panel test and why we can't do NIPT for triplets. This is because for the prenatal sample, as you know, is a very precious sample. And for this test, the validation tests have not been done for these products. So we will need to use the prenatal sample, and that's why it's difficult to obtain like prenatal sample to do validation tests for it. But like for microarrays or centroexome and centrogenome, they are already been validated. And also like why we can't do NIPT for triplets, the same reason as well, is difficult to get prenatal sample for the triplets to do validation. I can see there's another question saying, why is it better to use whole genome sequencing than microarray? So both tests has its own benefit, strength, and limitation. So for microarray is able to detect the copy number variation, the deletion duplication variant. And for whole genome sequencing is a comprehensive test for the whole genome and to detect single nucleotide variants and also a small insertion deletion.
Wow, I can see that there's so many great questions to choose from, but I think we are running out of time. If we haven't answered your question today, please don't worry. We will get back to you via email. There are very good and detailed questions here. I want to thank Clarice. Thank you very much for doing this webinar today. And I want to thank the audience for joining us today. I'm sure you were able to gain further insights into how prenatal genetic testing plays an essential role in the early diagnosis. I'm going to now launch a poll to receive your feedback on this webinar. We would appreciate if you would take a few minutes to fill this out. And like I said, please don't worry if we haven't answered your question today. We will get back to you if it wasn't asked anonymously. Thank you very much. Thank you, Clarice, and have a great day.
Thank you. Thank you, everyone.